I practice general clinical endocrinology. I am in no way or shape a cardiologist. I used to know general internal medicine, but I will say you tend to forget a few things. But I was asked by our esteemed president, who is a cardiologist, to give an endocrine take on certain things about cardiology. So that's like opening the Pandora's box. But I'm going to do some justice to it, I hope, in 20 minutes. So let's see what we achieve. Tarun, we have a malfunction. We need your password. Hello? While he puts his password in, I know everybody has had some breakfast. Lights are about to be dimmed, maybe. Don't go to sleep.
Touching this.
So type 2 diabetes, I'm going to tell you a little story in the next few slides, and that is my entire presentation. And just go with it and listen to me. It has many, many threads, and they are supposed to then be braided together. So type 2 diabetes, this is mostly about that. It carries twice the risk of CV disease and mortality. And we say diabetes control helps, but diabetes control alone is less impressive than helping microvascular complications, and we really don't have good answers for macrovascular complications. That's how this century has unfolded. So in can you see my arrow? No, you cannot. So what's that? I don't think they can. Don't worry. Don't worry too much about the slides. Hear me out. You can see a few things, and I'll see it with you. All right, so in 1998, this huge trial came out. It was the UKPDS trial. So, and that one, it was in the late 90s that we first found out that controlling diabetes tightly lowers micro and macrovascular complications. So microvascular complications, we all know, nephropathy, neuropathy, retinopathy. Those reductions were quite impressive. The cardiovascular reductions were not that impressive. And this was in 1998. So the slide is basically showing you microvascular complications in green. And then it's saying the green is good reductions. The orange is neutral. So macrovascular, cardiovascular disease, and mortality, it wasn't all that impressive. Although in the long term, that also turned green, that all right, yes, if you do control diabetes well, you do reduce cardiovascular morbidity and mortality. Now, so that was 1998. So, but this is all we had. We said, all right, there is some difference when you control diabetes well, let's do that. So we said, let's control diabetes tightly. Well, we created a new problem for ourselves, and we said, all right, now there is a lot of hypoglycemia, there is weight gain, it's a complicated regimen. What did we have back in 1998 and 2000? We had insulin, we had metformin, we had sulfonylureas, and TZDs, which is, I will use trade names here because we are not doing CMEs, Avandia, Actos. These agents were already out, they were being used. This is what we had back at the close of the 20th century and start of the 20th century. We are saying control it tighter. Well, controlling it tighter had its own hassles, but that's all we had. Now, if you move down that graph, it shows 3 other studies, ACCORD, ADVANCE, and VADT. These were 3 trials that came out sort of close to each other around 2007 and 2008. And I'm going to bring you back to these years over and over again in the next few slides because a lot of stuff happened in the world of diabetes at that time that we as endocrinologists lived through, and the patients lived through us. These 3 trials, they enrolled patients to see, in a way, how tight can you go? Let's think of it, they were diabetes trials. They were not necessarily cardiovascular trials. But they said, okay, let's enroll these patients with existing cardiovascular disease. They have diabetes. Let's try and control them as well we can, and let's see what happens. Well, what happened? You still had cardiovascular outcomes that were neutral. Microvascular complications did improve. And actually, infamously, the ACCORD trial actually showed increase in mortality. That is the one in red, which you can see the color at least. So now you are stuck. You have to control diabetes because it does give you other advantages. You have problems with trying to control diabetes, and you really do not have a very good separate answer for macrovascular complications or cardiovascular disease. And that is where the stage is around 2007, 2008, very much around the time of my practice even. All right. So then in the 21st century, like I said, we are saying, let's control diabetes tightly. We had hypoglycemia in those studies when we were trying to control them with insulin and sulfonylureas as a background. We don't want hypoglycemia, and we want sensitive testing for that. We had a lot of weight gain with hypoglycemia, sulfonylurea, insulin. If possible, we want to avoid that. Beta cell preservation. We don't want pancreatic function to decline as fast as it can when people have diabetes. Diabetes is a progressive disease. So type 2 diabetes, pancreatic beta cells, they go down in their capacity over time. And we don't want that to happen if possible. And yes, we don't want a complicated regimen if we can help it. And those were the things that were challenges back in the start of the 21st century. I drew a line over here saying, yeah, we want cardiac benefits, we want renal benefits, and we want cost-friendly regimens, because these things were important. They were at that time tied into tight control. We didn't have separate strategies for these other than controlling risk factors and giving diabetes good control. So in 2008, so we are stuck in these years, 2007, 2008. In 2008, this slide is very well known to everybody in endocrinology, and I hope it gets well known to people in primary care and people in every other field who deals with diabetes and diabetes complications in any ways. This is called the ominous octet. This was a very famous Banting lecture given by Dr. Ralph DeFranzo in 2008. Our traditional model that many of us grew up with of problems with diabetes, it was very simple. It was called the triumvirate. We said we have problems with the liver, we have problems with the muscle, and all that is resulting in hyperglycemia. Over time, this is what he presented. He said this is a multifactorial disease, and literally every organ is involved in contributing to hyperglycemia. You have brain dysfunction, you have increased hepatic glucose output, you have islet cell dysfunction, you have decreased insulin secretion, the gut is involved, the fat cells are involved, the kidney is absorbing more glucose than it should. So everything is involved in causing hyperglycemia. So let's not just target, oh, there is insulin deficiency, let's treat you somehow with insulin. And this message, it resonated extremely well with how we were trying to handle diabetes at that time. There were a multitude of medications already available. We had metformin, sulfonylurea, insulin. GLP-1 analogs were already out in 2007, 2008. Exenatide or Byetta was already available. Victoza had come along. The other GLP-1 analogs that we have these days, they are called, you have a couple of them outside, Ozempic, Rybelsus, Trulicity, you know these names. EZDs, Avandia was available at that time, Actus was available at that time, DPP-4 inhibitors, the gliptins, sitagliptin, saxagliptin, Januvia, Onglyza, Tradjenta, those things were available. I put the slide for SGLT2 inhibitors here, own this column at the end. SGLT2 inhibitors, they only came around in 2013, but I was making a chart of diabetes medication comparisons, so I put it here. And I know you guys cannot see all this very well, but what I was trying to highlight in this grid is back with UKPDS, just like I said, there was a lot of hypoglycemia, struggles with weight gain, beta loss, beta cell loss, and our strategies, we didn't have any extra benefit, any extra cardiovascular benefit. And so back in 2007, 2008, when we already had GLP-1 analogs, TZDs, and DPP-4 inhibitors available to us, we said we need to harness these things in our diabetes management. And that's what, as endocrinologists, we started to do. We were already doing this. So in 2008, on the left was the official ADA algorithm, which basically was, it was treat to failure, famously or infamously. Diabetes is diagnosed, lifestyle and metformin, then when that fails, add sulfonylurea, and when that fails, add insulin. I mean, you've set up the patient for just failure. Each time he comes, he feels like a big failure because something gets added, it causes hypoglycemia, he doesn't like it, then he's like, oh my God, now I'm on insulin. But what were we doing in reality? In endocrinology, a lot of us were already doing these things. Lifestyle, yes. Cannot minimize that. Nothing works without it. So lifestyle, metformin, GLP-1 analogs, which is, at that time, exenatide and Victoza were available, and then maybe TZDs, Actos or Vandia, if you could use it. And then eventually we moved on to using SGLT2 inhibitors when they became available in 2013. Canagliflozin or Invokana was the first one. So in endocrinology, we have been using these products for many, many years now, 10 plus years or more. And a lot of us are very familiar with these products in the diabetes world. So yes, I'm still setting the stage. This is a very, very busy looking slide, but this is from cardiology clinics, and this summarizes things beautifully. In 2007, this was an article, a meta-analysis. Again, an infamous meta-analysis that led to something good eventually. This was published saying that rosiglitazone or Avandia, it increases risk of MACE. I'm sorry, it increases MACE. So, it was already FDA approved, being used liberally. It led to a lot of bad press, lot of anxiety. Eventually, it was taken off the market. 2020, we had known none of that was okay, but that meta-analysis in 2007 led the FDA to say every diabetes drug that is now going to be approved must meet certain cardiovascular safety standards. And this is what started this flood of cardiovascular outcome trials for every diabetes drug from there on. And we just stumbled upon cardiovascular benefits of GLP-1 analogs and SGLT2 inhibitors. We were just trying to look for non-inferiority for diabetes medications. But instead you found Victoza, Ozempic, Trulicity. These are GLP-1 analogs. Victoza is liraglutide, Trulicity is dulaglutide, and Ozempic is semaglutide. These products, these are multitudes of trials that showed that they impacted cardiovascular outcomes, not just non-inferiorly, they actually gave some advantage to cardiovascular outcomes in patients with diabetes, something we had never seen before. Side by side, these SGLT2 inhibitors, what are these? The gliflozins, the canagliflozin, which is Invokana, Jardiance, which is empagliflozin, Farxiga, which is dapagliflozin. These studies, they all again started to show cardiology benefits, and then renal benefits. And then people got bolder. They then started to say, all right, is this benefit limited to diabetes? Well, then they conducted some of these trials in non-diabetes patients. And again, you saw that there is an advantage to using these drugs outside of diabetes for cardiovascular and renal reasons. And that is where we are today. These drugs are spilling over from the diabetes world onto the non-diabetes world. It is good, but it creates anxiety in a lot of people because they are brand new drugs with so-called sugar-related issues for people who don't deal with blood glucoses all the time. And so people are now having to familiarize themselves with a lot of these medications and how to use them. Now, I will tell you, I have no reason to use them in my practice in people outside of diabetes, but I can tell you my experience in how we have been using them, and this is what the next few slides will do. So our algorithm has changed considerably from that simplistic one to lifestyle plus metformin, then sulfonylurea, and then insulin. This is what it has become. This is the ADA guidelines for 2022, and it's a huge departure from where we originally started. Everything was one agent followed by the next for the longest time, and in our latest guidelines, at least the guidelines are recognizing that metformin doesn't have to be the starting point. Lifestyle should be the starting point. Yes, that is true. That has not changed. But they are, at the very outset, they make this, I don't know if you are able to see, on the left, right at the top is a little red bar. That is saying if somebody has diabetes, see if they have CKD or cardiovascular disease, see if they are at high risk for cardiovascular disease, and if they are, irrespective of what their starting A1C is, irrespective of whether or not they're on metformin, this, especially GLP-1 analogs and SGLT2 inhibitors, because they have now been shown to have so much benefit in this population, the recommendation is to incorporate them early. It is important to remember, when we talk about cardiovascular illness, especially in people with diabetes, cardiovascular disease does not happen in a day. It develops over years, and so the earlier you make an impact, the better your outcomes are going to be. Trying to engage established patients with established cardiovascular disease and established diabetes complications, that gets very hard to show good outcomes in because they already have significant established disease, which is what happened in those ACCORD, ADVANCE, and VADT trials. So for us, even this is a good departure in a way to allow us to at least think of these agents early in our algorithm. So in the next few slides, I will now tell you about a little bit about SGLT2 inhibitors, a little bit about GLP-1 analogs, and I will mention continuous glucose monitors briefly because without sensitive monitoring, sometimes I don't know what I'm doing and the patient doesn't know what he's doing. And yes, I will discuss every study that I alluded to earlier. No, I am not going to do that. So SGLT2 inhibitors, what are they? And I like to talk about physiology because a lot of the guidelines, in the end, it is about understanding what the physiology of our body and all these medications is. So SGLT2, these are sodium glucose co-transporters. This is what these receptors are. SGLT2-1, these receptors are mostly in the gut. They exist in the kidney also, but less. SGLT2 inhibitors are largely in the proximal tubule. The SGLT2 receptors, they allow sodium glucose co-transport back into the bloodstream, so they are responsible for reabsorption of ultrafiltrate. So if you go back to your physiology, this is where SGLT2 resides. On the left is the lumen of the proximal tubule. Then in the blue is the cell, and then on the right is your bloodstream. So the SGLT2 receptor in green resides right at the junction, that's what it's controlling, the absorption of glucose and sodium from the lumen of the proximal tubule, and it's going to take it into the cellular cytoplasm, and then ATPase and GLUT2s are going to then push all these things into the blood. So glucose and sodium co-transport is happening through SGLT2 receptors. What do you think would happen if we block it? You're not going to absorb sodium and you're not going to absorb glucose. And because these were supposed to be drugs that controlled glucose or hyperglycemia, originally it was the glucose reabsorption that was being prevented. That was the focus of teaching and the focus of everybody's concern. But as you can see, these drugs, they cause natriuresis also. And it's the natriuresis that may be responsible for all the effects of SGLT2 inhibitors that are being seen outside of diabetes. A lot of this graph, again, it's too little, but I put it here only if somebody is interested in looking at these slides later. You don't have to look at each one of these boxes independently. The idea here is to simply suggest there are a lot of possible mechanisms that have been proposed for how SGLT2 inhibitors affect sort of stuff outside of diabetes. And a lot of it people think is because of natriuresis, that you are affecting sodium transport at the level of proximal tubule, and that is changed, then it will have downstream effects. This is a big diuretic effect and more. So SGLT2 inhibitors, they cause osmotic diuresis, they cause glycosuria. That glycosuria is insulin independent, very important to know, especially in the diabetic population. And so the glucose reduction in the bloodstream is independent of insulin. And then they cause natriuresis, which has become more and more important these days for my other friends, my nephrology and cardiology friends. The side effect profile and the therapeutic profile, it all sort of, you can now derive it all from these effects that these drugs are causing. If something is going to cause osmotic diuresis because of glucose, what can you get? You can get a lot of dehydration and a lot of thirst if the osmotic diuresis is very brisk. When is the osmotic diuresis going to be super brisk? If the hyperglycemia is very severe. Ergo, where should you not use this drug? If somebody is very severely hyperglycemic, if the blood sugars are 400, that is not the time to use this drug. They are going to dehydrate very severely. Could you use it if the blood sugar is lowered and then put it on 2-3 days later? Absolutely. Now the osmotic diuresis is going to be more controlled. Glycosuria, same thing. If the blood sugars are very high, that's a very high glucose load that is going to get delivered to the kidneys and then urinated out. The genital yeast infections are going to be more. Any patient is going to be more at risk for them. But if the blood glucose level is not that high, let's say it's 220, 230, you can use it more safely then, it's less of a nuisance. Insulin-independent glucose reduction, this is important to know, and it comes into play mainly in populations, the diabetic population. The non-diabetic population probably is not going to have problems with this because their glucose metabolism is intact to begin with. All you're affecting with these drugs is their natriuresis. You're not causing a whole lot of dysfunction in their glucose gradient. But the insulin-independent glucose reduction is what sometimes causes ketoacidosis in the diabetic population. The glucose is low, so the insulin also drops because the body thinks it doesn't need to make any, so the body is now exposed to relative insulin deficiency, and that causes ketone formation. And so it is important to know this It doesn't mean you cannot use these agents in diabetic populations, but then if you understand the mechanism of ketoacidosis and what scenario it may have happened in, you can avoid it. And then I said natriuresis, that is what is believed to be giving the cardiorenal benefits outside of glycemic status. So let's quickly talk about GLP-1 analogs. I like to show this study because people who are, again, not in endocrinology don't always get to see these slides. This was a sort of a proof of concept study. This was back in early 90s by Nock et al. They were the ones to show that if you infuse GLP-1, glucose levels fall in the body, but more importantly, insulin levels and glucagon levels, they both change, and they both change in relation to the blood glucose levels. So that basically told us two things. One, you are using something that changes insulin. Two, you are using something that changes glucagon, which were never able to address. And three, both these things are changing in relation to glucose. So you're not getting any hypoglycemia with this agent, so to speak. Same thing is true of SGLT2 inhibitors. That whole mechanism is glucose dependent. So if the blood glucose is dropping, all that ultrafiltration of glucose stops. So hypoglycemia typically doesn't occur. So the GLP-1 pathway, if you eat something, my gut, it makes GLP-1, that activates something, which we will not talk about because I have only 4 minutes left. And then in people with diabetes, GLP-1, the thought is it's deficient and it's not available in, the response is not that brisk. So GLP-1 analogs, it's almost like a neurotransmitter and a hormone that I'm supplying from outside that is missing in these patients. How they cause cardiac benefits, actually it is not well understood, and definitely not outside of diabetes population. That data doesn't exist at all. But in patients with diabetes, GLP-1 analogs are very powerful agents, and it is good to have them on my side because if they give me cardiac benefits, so much the better. They cause greater than 1% reduction in A1C, they don't cause hypoglycemia, they induce weight loss, and yes, they have cardiac benefits. When do you favor these agents? If the patients are metabolically challenged, which most in Ohio are. If they have underlying cardiac risks or disease, more reason for me to give them. I was using them already, but now more reason for me to use them. If somebody has additional comorbidities and they can be helped, why not? When do you not give these agents? It's in the package inserts. These agents can cause pancreatitis in some patients. It's not that common. And if people have existing gastroparesis or very severe GI issues, these drugs, they cause reduction in gut motility. So sometimes it's not a contraindication, but those patients may not tolerate it well. And then last but not the least, I'll give you a brief version of continuous glucose monitors. There's a booth outside on Libre monitors. There are others. There is Dexcom and there is Medtronic. Why are they so important to us? I want people here, I really wanted to show actually this slide, that A1C is not the entire story. It is important for people when they're dabbling with these medications that lower glucoses to understand A1C doesn't tell you everything. People can have very severe recurrent hypoglycemia, their A1C will be falsely lowered. They may have gone through blood transfusions, they may have blood disorders, they may be on dialysis, they may be on erythropoietin. All these things, they change RBC turnover. A1C is assuming that RBC lifespan is 120 days, and that's why it's a 90-day average. Anytime you change these parameters, A1C starts to become inaccurate. So it is important to understand for us as clinicians as well as for the patients that A1C, it's not a report card. Everything has its limitations, and so does this. So then we talk about what do CGMs do? Person A is in blue, better controlled. All the blood sugars, that whole line is within the yellow, or they are spending more time in range. Person B, huge excursions in sugars, highs and lows. They both may have the same A1Cs. They may be checking their blood sugars 3 times a day and missing all the fluctuations in between. And that is why we like CGMs, and we like knowing how much time are people genuinely spending in euglycemia, and how much time are they spending in oxidative stress. So we like CGMs in this day and age. Like I said, they come in multiple shapes and sizes. All of them have their pros and cons. They're all popular. Take a little bit of work in getting patients to use them, but they are good agents. And last but not the least, I wanted to leave you with this slide. I cannot say enough how much healthy lifestyle, with or without diabetes, impacts cardiovascular disease. We do a lot of things. We intervene, many people don't smoke. They will reduce their alcohol consumption. But when it comes to moderate to vigorous physical activity, only 30 minutes for 5 days a week. That's all it takes. Most of us don't do it. We have every excuse in the book, and then we say, well, let's not use medications. Well, I say you need both. You need medications when you need medications, but without that layer of lifestyle, exercise, and diet, none of it works. If it does work, it doesn't last. So the sweet spot here is modify your lifestyle, incorporate SGLT2 inhibitors and GLP-1 analogs early. Don't get stuck in metformin and sulfonylurea for the rest of somebody's life. And if that helps the art, so much the better. That's what I had today. Thank you.